Thank you, Dr. Burkule, for your excellent presentation. It was, in fact, a deep assessment, an elaborate assessment about the diagnosis as well as the outcome of hypertrophic cardiomyopathy in the background of a patient presenting with left ventricular hypertrophy. So if let us see if we have any questions, or the audience expecting to get some answers from some comments from my co-chairs or others can start.
Dr. Nitin, wonderful presentation.
We have got 5 minutes, so be quick. Yeah.
Yeah, thank you very much. Wonderful presentation. So many a time we see hypertrophic cardiomyopathy patient, there are multiple factors which causes angina. There is demand supply mismatch. There are many other issues as well. So it has been a common practice whenever we get a diagnosis of hypertrophic cardiomyopathy, we ask for an invasive coronary angiogram. So many a time I don't think what is the rationality. So how to assess the ischemia in presence of hypertrophic cardiomyopathy, and what are the ways out? Is it always mandatory to go for a coronary angiogram, or where is the exact point where I advise coronary angiogram?
Yeah, I think that's a very pertinent question, because this is our regular clinical dilemma, because these patients have a lot of microvascular angina, as you said. Now the problem is, if you do a stress ECG, it is worthless because the ECG resting is already having STD changes. If you do stress echocardiography, that is also not very useful, because in hypertrophic cardiomyopathy, the sensitivity of stress echocardiography is poor, both dobutamine and treadmill stress echoes. If you go for perfusion scans, so suppose you go for a adenosine stress perfusion MRI, or if you go for a perfusion thallium, they also show a lot of defects related to the fibrosis. So most of our non-invasive stress imaging has terrible limitations in hypertrophic cardiomyopathy. So I think it remains only with a CT coronary angio or an invasive cath angio. So I think clinically, if we are convinced about the angina, I think if we don't want to go for an invasive study, then probably CT coronary angiogram comes in handy. Many times for the younger patient, I just get a CT coronary calcium score done, and if it is negative, then generally I'm relaxed that probably he may not have it. Now, however, for a past middle-aged patient and with other coronary risk factors, I think it is better to get a CT coronary angio done. Then at least we know that next 5 years we don't have to worry about his developing any significant coronary disease. Of course, it's not a golden rule, but we have to accept the limitations of all our stress imagings.
My question.
Now,
Yeah.
may I just add to Arindam? Arindam, in our experience, it is distinctly uncommon for HOCM patient to have significant atherosclerosis as well. That is number one. Number two is that anybody above 35, if there is acceptable angina, class 2 to 3, and if there is high other atherosclerotic risk factors, that is very important, other risk factor, then it's better to have a CT angiogram. Otherwise, if it is a younger patient or no other risk factor, it's better to treat HOCM, and most of the time the angina is relieved and you need not explore at that point of time. That is my view. Shunit.
There is one issue, Shomitra. If the patient has a high risk for sudden cardiac death, and if I'm planning for ICD or CRT, something like that, before that you should do a coronary angiography to rule out extensive coronary artery disease or not. That is one very important indication.
Shunit.
Yeah, my question is in a patient who has a subtle changes of voltage criteria of left ventricular hypertrophy, T wave inversion in the precordial and lateral leads, and the echocardiography from a experienced echocardiographer rule out even any diastolic pathology. And the patient is clinically asymptomatic. He is not hypertensive. He is not diabetic, and no family history of premature coronary artery disease. So these patients is I think we see sometimes, not very often in clinical practice, how to follow up them. The problem is even they go for a routine ECG, after sometimes it shows abnormality. So just I'm not aware how to do it. So
before an echocardiography specialist answer the question, from cardiological point of view, I believe these are the cases who would be getting a lot of benefit from CMRI or MRI for the diagnostic evaluation.
Dr. Burkule, please.
Yeah. I think this is also a very important question because these are almost our day-to-day issues of patient having non-specific STD changes, mild elevation. Echo doesn't show any hypertrophy. So first thing I always tell my fellows is do one contrast echo and scan the LV from base to apex. Many times you have got a very small focal hypertrophy, somewhere say apical lateral wall, or someone say inferior mid-inferior septum, and it is very easily missed in all our regular 3 short axes and 3 long axis views. Very easy to measure. So whenever there is an ECG changes, I always tell them, let us do a LV contrast opacity and find out that focal hypertrophy. If you don't get that, then the next, I think the best thing is to do a good stress echocardiography, because if it is, these are non-specific changes, and if it is an athlete's heart, the stress echocardiography will come in handy to show you a nice hyperdynamic heart and will rule out any coronary artery disease. And if the patient's basal GLS is normal and the longitudinal functions is normal like E primes and S prime, then very unlikely that we are dealing with any sarcomeric cardiomyopathy. However, if the patient has got any family history of any cardiomyopathy, then probably we will follow this patient every 3 to 4 yearly.
Two quick questions, Nitin. One is, when the septal hypertrophy abruptly ends in the midway or two-third, that might give a visual creation of an aneurysm. How to differentiate with a true aneurysm? And number two, when an HCM patient goes on to have ejection fraction below 40, do you give the usual all medicines, including the vasodilator RAS blockade, like heart failure or reduced ejection fraction, or do you have some limitation?
This is also our regular clinical issue. I'll take the second issue first. That when the EF falls to, as we know, the EF falls to 50% itself puts them at a very high risk for both sudden cardiac death and heart failure. If they do not have a dynamic obstruction, I think the entire guideline directed medical therapy for HFrEF we can unleash on the patient. So it's very easy to do that. Question comes when they have a dynamic obstruction. And then I think probably there is a serious limitation in giving the vasodilators. However, we can go to the maximum guideline directed beta blockers for these patients for sure. But most of these patients, as they start dilating, the dynamic LVOT obstruction goes on reducing. As the myocardial fibrosis progresses, the dynamicity of LVOT obstruction goes down. And we get a leeway to add the ARNIs or ACE inhibitors, or add small dose of spironolactone and so on and so forth. And about the first issue was related to
aneurysm, when
aneurysm,
false sense of aneurysm. Yeah.
Correct. So many patients have got that basal thickening and the septum looks very catenoid, and we don't know whether it is an aneurysm or not. I think here also, I think the best way on the echo is if the window is not that great, to look at the LV opacification contrast, and I think that can sort out the matter very well, that we are not missing with a apical aneurysm kind of a thing, because most of the apical aneurysms will be very thin. Unlike where there is a catenoid septum, the apical thickness will be very well preserved and you will have that triangular apex. But however, if you have got a globular apex and a very thinned out myocardium there, you are sure that this is a developing apical aneurysm, and which is a very high risk factor. And when in doubt, obviously on the LG and MRI, you can make out both the things.
Burkule, one small question, please. One short question. Although ACC-AHA does not include LVOT obstruction as a prognostic marker for hypertrophic cardiomyopathy, but what is your call on that particular factor?
I think those who are having resting dynamic obstruction, non-provocable resting dynamic obstruction, I think they are at a high risk, because obviously there are a lot of back pressure changes. Generally, they have much larger left atrias. They can develop atrial fibrillations, which can be very fast, which can not only produce the silent cardioembolic strokes, but they can also push the patient into acute pulmonary edema, so on and so forth. So though it doesn't fall as a risk factor in the current ACC guidelines, but I think patients with dynamic LVOT do poorly than those patients who do not have an obstruction.
Thank you, Nitin, for the very exciting presentation. It was fascinating, but because of time constraint, we have to stop over here. Thank you very much. And may I invite the next speaker, Dr. Paramartha Bhattacharya.
Soumitra, just an issue.
Yes.
This is Deepak Adata, just an issue. Dr.
Yes.
Achyut Sarkar has posted a question on the chat box. Can you please ask Nitin to answer that?
Sure. Is the length of PML also not important like AML. Your comment on the entity with mild or no enlargement of septum, but there is LVOT obstruction. So 2 comments. What is the role of PML length? And secondly, there is no enlargement of septum, but LVOT obstruction. These 2.
Yeah. The second one are probably some formifrosity, that you don't have much thickness of the septum, but you do have a dynamic LVOT obstruction with elongated leaflets. I think these are probably definitely some phenotypic expression of an underlying genotype, and which can get clarified only if you do the gene panel for these patients to look for the myosin heavy chain and the other genes, and you get that hypertrophic cardiomyopathy gene panel. However, for the first question was about the PML length. As we know that most of these patients with systolic undermotion, they have both elongated AML and PML. But generally, when there is a whenever there is a systolic undermotion, we generally don't have much importance for the length of the leaflets. The length of the leaflet comes into play or comes into importance when we are looking for a phenotypical expression of a hypertrophic cardiomyopathy in the first degree relatives of a proband. Like you have diagnosed a patient of HCM and now you are screening the relatives of the patient. In those patients, if there is no hypertrophy, but you find a subtle increase in the AML length, then probably you should follow that relative much closely, because they may future develop the hypertrophic cardiomyopathy, because every decade a few new patients get added with hypertrophic cardiomyopathy. Or if you have got all the resources, then you can do the gene panel for all the first degree relatives, but that works out to be very expensive. So the humble echo is the best. So there, that AML length actually makes a difference to pick them up early. About the PML length, I really don't know, but AML length is very well known about.
The very last quick question from Dr. Vinay Vadgaonkar. What is the AML length criteria? At what length will you intervene the AML to repair it or shorten it?
Actually, I can't give you a ballpoint figure, but most of these AMLs on the elongated AMLs on the HCMs, you will find them 2.8 centimeter, 3 centimeters or more. Most of our healthy people will have less than 2.5 centimeters. So I can't give a ballpoint figure as such. It's more, I think, a qualitative way of looking at it. Looking a large redundant AML, and that is bowing towards the septum, and patient doesn't have any hypertrophy. And if it's a first degree relative of a patient of a hypertrophic cardiomyopathy, then think that this patient probably in future may develop it. So follow him every 3 yearly for their phenotypic expression of the HCM.
Thank you, Dr. Burkule. Now, may I invite Dr. Paramartha Bhattacharya for the second case scenario, please?